Good morning to everyone on this cool spring morning. I'd like to welcome everyone to Grand Rounds. Today, our Grand Rounds is going to be given by Dr. Mohannad Abu-Hilal. Dr. Abu-Hilal is an associate professor, and he's the head of Dermatology Division at McMaster University. He's also the head of the Dermatology Service at Hamilton Health Sciences. He is the program director of the Advanced Clinical Dermatology Fellowship. His clinical and research interests include severe psoriasis and atopic dermatitis, immunobullous diseases, cutaneous lymphomas, and skin manifestations of systemic diseases, particularly rheumatic diseases. Today, he is going to be providing us with Grand Rounds. The topic will be a decade of breakthroughs in skin science and a new era of dermatology. So thank you very much, Dr. Abu-Hilal, and we look forward to listening to you today.
Well, thank you, Mohammed, and good morning, everybody, and thanks for this for the introduction. First, I just would like to remind ourselves how privileged we are to be living on this land that, our beloved indigenous and native people called home for thousands of years. So I think, I will talk to you guys about, the changes, the massive acceleration that happened in dermatology over the last, 10, 15 years, particularly in the last 5 years. Before we start, this is my disclosure, nothing relevant to my talk today. And as Mohammed mentioned, the goal of this presentation is to review the breakthroughs and the new therapeutics that happened in the science of dermatology over the last 10 years. In fact, if I want to simplify it, the goal of this presentation is hopefully, to change, kind of the conception some people they have that, dermatology doesn't change, doesn't impact, doesn't influence, kind of outcomes, doesn't influence quality of life. And again, to review our role in managing some severe complex diseases that 10 years ago, 8 years ago, 15 years ago, we used to think that there is no treatment for them. And to start, kind of my talk today, I wanted to share this busy slide with you. And again, it has a bit of a bunch of some, skin conditions, as you can see, different, kind of ages, different backgrounds. And it's actually, the first one to the left, as you can guys see. It is a couple of patients that they suffer from a disease. It's called alopecia areata totalis, which is an immune condition that, leaves you with no single hair follicle. There is no one hair on your scalp. You also lose hair from your eyebrows, from your eyelashes. And it has a bit of, kind of psychologically disastrous outcome in the patient. And reminds me of, when I finished my residency, 11 years ago, I had a friend, he's a pharmacist. His name is Ali. He's not here today with us. And he suffered from alopecia areata totalis. And I was just finishing my residency and I was treating him. And, I was giving him those potent topical steroids, and I'm doing all these, kind of injection with the steroids in his scalp. And then, after 7, 8, 9 months, we were out, me, him, and a couple of friends. One of them is a cardiologist. And I saw him, I was like, oh, Ali, take off your hat. Let me see your scalp. And when I looked at his scalp, there's, a bit of, kind of few, I don't know, 50, 40, 50, 100 hair follicles coming out of his scalp. And I said, wow, it looks great. Look, there are some hairs growing there. Finally, we can see some hair, growing there. I'm so happy. That's a big change. That's literally what I say, like, it's a big change. And then, he looked at me and, I can tell, like, he didn't like this comment. He was upset. He was, disappointed. And he actually, kind of confronted me. He's like, Mo, are you serious? Like, after 8, 9 months of treatment, I'm using tons of steroids. My scalp is thinned out. and that's what you think it's a great improvement. And since then, quite honestly, I started to think, you know what, maybe it's true. You know what, at that point, what I was thinking, you know what, maybe we don't do a lot for those patients in dermatology. And I started to think about some other patients, and this is what I'm going to take to you guys now. I'm going to take you through a bit of a journey, and I want to run the clock back, and I want to see, you know what, how we used to do for those patients, what we used to do for those patients, how were they suffering, and did it change now? Like, is there a difference between what we do the things now for those patients compared to what we used to do, like, let's say 10, 11 years ago? And again, going to those, kind of cases, I'll just, kind of throw some random cases. This is, again, two cases, two patients, alopecia areata, totalis. It's, as I said, it's a condition that comes with a huge psychosocial impact on the patients, whether if it's a male, a female, and those patients, kind of both had depression because of this. The lady on the left, and again, those assumed patients, she, since she's been diagnosed with the alopecia areata, she never, been engaged, in a relationship. She was isolated. In fact, once attempted suicide. And, those two patients, kind of 10, 11 years ago, or even, 8, 9 years ago, we treated them with with potent topical steroids. We use even topical tacrolimus. We give them high dose immunomodulatory agents. We give them high dose of prednisone, and none of them was effective. And that's actually the case for almost all patients then. Nobody was responding to those medications. And I do remember those patients, they used to say, either, oh, Dr. Abu-Hilal, thank you. And I can see that, I wouldn't say they didn't like me. It's like, you're not helping us. They would just leave, disappear. And I do remember one of those patients in the past, he was telling me, kind of almost as like, I don't know what I'm doing. Well, again, it's not I'm not knowing what I'm doing. It's just there was nothing that we can do for them. And the same thing applied to this lady. So a lady also in her early 30s, and she was diagnosed with this autoimmune condition called vitiligo that was affecting major part of her body, including, kind of face, arms, hands and feet, even the exposed areas. And again, because of this, she was diagnosed with severe depression, anxiety, again, social isolation, massively reduced quality of life. And again, the same thing, we tried all the topical steroids, the topical tacrolimus, the same story with the prednisone, oral azathioprine, cyclosporin, methotrexate, and even, we tried phototherapy. None of them was working, was not helping the patient. And again, those usually patients disappear and they start jumping between physicians because they think that, we don't know how to treat them. Well, again, there was nothing. Even our beloved, kind of little angels, this is a medicine, but I just want to share this. Again, a baby with mother, diagnosed with hemangioma, which is a birthmark, collection blood vessels, and it keeps growing until you reach, a big size by the age of, kind of almost 1 or 2 years. Then, over 10 years, start to slowly regress. And I do remember those patients, one of those mothers came to me, like, for example, this. And I was discussing, what we can do. And first of all, it's like, oh, don't worry. It's not cancerous. It is not going to do anything for her. And the mother was like, I know it's not cancer. I don't care about cancer. I care about the psychosocial development of my daughter. That's she's going to be asked. She's going to be probably bullied. And what we can do for them, there were two things. We either can give them very high dose prednisone. A lot of them, they end up with Cushing syndrome, those babies. Or we would send them for surgery and they end up with a nasty, nasty, nasty big scar. The same thing with this thing. That's something you guys see a lot in the medicine, in the ward, patients with this severe autoimmune condition called Pemphigus vulgaris. They have this recurrent, severe, debilitating blisters and erosions that would happen any part in the body, most of the time diffuse in the trunk extremities and also in the nose and inside the mouth and even the private area. And those patients, they would be just frequent flyers to the hospitals, like even till now, but, even much worse in the past. This patient was admitted like 5-6 times, in the last 12 months. And, we treated him with everything possible, potent steroids, prednisone, we would give him very high dose. He would do well. You go down just like in flare up. We give him some, again, immunomodulatory agents. And either they have side effects, would be ineffective, Or you know what, they would have side effects. I do remember those patients with psoriasis, sometimes we give them methotrexate until, you know what, they just liver explode. So again, 10 years ago, this patient was admitted many times. We tried everything for him, nothing helped. Psoriasis, you know what, a lady or a guy, you know what, with severe psoriasis affecting 80% of their body. You know what, and I do remember, you know, their words, like, you know what, some of the guys are like, oh, I wish I have a girlfriend. I look disgusting. That's their word. And, you know, that's how they would feel. I am embarrassed. You know what, people ran away from me. And you know what, look at me, you know, my skin is red, scaly. And again, you know, I do remember one of those patients 10 years ago, he was dealing with severe depression, attempting suicide multiple times because he was not happy with, you know what, you know, his health, particularly the skin. Again, similar story. We used to try everything, what available in our hands, topical steroids, UV and methotrexate. He was having a lot of, you know, drinking issues, and you know what, with the methotrexate, you know, which was partially effective, was not helping his joints at all. But he also developed a severe hepatotoxicity. Patients with, you know, atopic eczema, you know what, the same thing. They are frequent flyers to the hospital, to the emergency. They end up with a lot of, you know what, recurrent infections, skin infections, sometimes even sepsis, herpes infection, eczema herpeticum, and they end up with herpes zoster. You know what, this patient 10 years ago, we were not able to treat her. There is nothing in our hands other than topical steroids for eczema. This patient, you know what, she's in the peak of her, you know what, productive age, in her 30s. She quit her job. She had unstable relationship with partners because of this. And even patients with, you know, some severe immunological conditions like dermatomyositis. In the past, and even, you know, until recently, you know what, our friends in rheumatology, you know, they would treat them, and you know, a lot of times, you know, their muscle would improve, similar to this male patient. You know what, he would having myopathic dermatomyositis, and you know, he was receiving a lot of treatment, which made his muscle much better, you know, in a way. But his skin manifestations, I'm sorry if Zoom doesn't show very well, he was having, you know, the shoal sign, the V sign, some of those manifestations of dermatomyositis. And despite being on all these, you know, IVIG, hydroxychloroquine, and other things, he would still have those manifestations. So that's why, you know what, we used to think that, you know, dermatology comes with a lot of disfigurement, a lot of discomfort, depression, death, mortality, not probably high as other conditions, but, and even disablement. So very high morbidity, a huge psychosocial impact on the patient. So what was the problem? Why, like 10 years ago, there was no treatment for those patients? As you can see, this is just a sample of many skin conditions that, you know what, at a certain point, I accepted that, you know what, that's true. You know what, maybe we can diagnose, you know, those patients, but we were not able to help them and influence their life. We cannot just, like, you know, kind of impact them positively. We cannot do some radical treatments for them, radical changes for them. So the problem that, you know what, we didn't have a lot of understanding of the pathophysiology of the most inflammatory skin and malignant diseases. We'll talk about it in a second. Psoriasis, we used to think, oh, you know what, it's just inflammation of the skin. Just give him one of those immunomodulatory agents that, you know what, just reduce the inflammation. And the other issue, which is interestingly true, you know, our partners in the pharma industry, you know what, everybody was focusing on the big markets and the big fields, namely, for example, oncology, malignant hematology, diabetes, cardiovascular, musculoskeletal. And despite that, probably one of every 4 or 5 individuals, they would have a skin issue, which could be mild, could be, you know, some acne, could be a bit of mild eczema. But, you know, those, you know, kind of folks at the pharma industry used to believe, or tell now somehow, that, you know what, dermatology is a bit of, you know, kind of a small size, a small field compared to the kind of, you know what, other fields in the house of medicine. And what did that lead again to? There was a lot of unmet needs in the treatment of dermatology and diagnosis, pathophysiology, and also in therapeutics for dermatology. And even, you know, when things change, trust me, when things change, didn't happen because in the past, that's what people told us, you know, our, you know what, colleagues, you know, 20 years ago, you know, though people in industry and research was not focusing in dermatology, but what happened that, you know what, thanks to our folks in rheumatology, you know, the whole story started with, you know, psoriasis. So, you know what, they came with those TNF alpha inhibitors, like maybe 13, 14 years ago, for mostly like psoriatic arthritis and some other types of arthritis. And, you know, everybody noticed that, you know, some of those people, they would have psoriasis, and the psoriasis was improving, at that point would be thinking of, wow, great way. So again, those were not made for psoriasis. They were just treating some other musculoskeletal, namely arthritis. And you know what? That's opened the gate for a lot of, research in dermatology. And since then, since, they noticed, oh, you know what, there's some inflammatory skin diseases. Oh, let's do some research. And you know what, they sponsored, they participated, they helped. And you know what, there has been a massive acceleration in the science of dermatology research. And we have a lot of therapeutic and diagnostic updates. Look at this. So this is, the therapeutic pipeline for dermatology in 2021. And as you can see, dermatology is almost like, brown. And you can see in all phases, like phase 1, 2, 3, pre-registration and all phases, it's almost like, 3%. So out of probably 100 medication, there's 3 medications, in the science, in the field of dermatology, which probably for us is not great, but that's a huge change. If you ask anybody, in 2010, 11, if you have probably 500 medications being, developed, probably there was maybe one, and again, as we discussed, it was not actually made for psoriasis or for dermatology. It would have been made for, some other indication, and it was going to be used also for dermatologic condition. So that 3% that now doesn't look great, it's great, actually, it's good, but we want it to be higher. But this is a huge change to 10 years ago, when, there was almost no pipeline, there is no dermatology, new therapeutics, there is no deep research in dermatology. And again, if we want to, run it into psoriasis because we say it. So look at this patient, a very massive psoriasis. We discussed him as, case 10 years ago. I mean, those are not like 10 years ago. Some of them are more case report than our current patients, but I just use it as to narrate the story. So this is a patient with psoriasis, as you can see, covering like a huge part of his body, nails, body, arms, private area, face, scalp, huge impact in his life. So psoriasis is an example, as we discussed, like, 10, 12, 15 years ago, we used to think, oh, psoriasis is just thickening of the skin. You just need to use a moisturizer. Then, what? We talked about the story. Then, there was more interest in research. They found that there is some inflammation in the skin, some just inflammation. We used some of those immunomodulatory agents. Then, the TNF alpha inhibitors working for them, for those patients, we found that, oh, maybe TNF alpha is playing the biggest role, which actually now we found that that's playing a role, but it's not the major role. It's kind of, I wouldn't say a minor role, but it's not a huge role. And, the research progressed until now. We know about some, certain molecules that they are the masters of master cytokines of psoriasis, what we call interleukin 23 and interleukin 17. And inhibition of those, molecules will result in a very, very excellent improvement in them. So look at this. We have now at least probably 9 or 10 agents for psoriasis, as you can see. It started with infliximab and adalimumab, which we discussed that they were mostly for arthritis and then psoriasis. But, a lot of new agents came to the market. And again, look at this. Until 2008 or 2006 and 8, there was just 2 agents approved, and those agents approved because of the arthritis. Look at this. Again, for almost, until 2013, 14, there's just 2 agents. And, between 2015 and 2023, actually, there is 2-3 more agents came in 2002 and 22 namely. And we have at least now 8-9 agents other than, adalimumab and infliximab. But not only this, not just the concept of having new agents, even, those patients with psoriasis, our goals changed a lot. So, and even, the safety profile for those medications, again, when infliximab or, adalimumab or, etanercept came, when we started using them, we used to be extremely happy that the patient would improving by 30, 40, 50%. Like, oh, half of our patients are achieving, 50% improvement. And that was like, wow. But again, our understanding in the research and, all this acceleration in the research and development of medication led to different outcomes, to different goals. So look at this, the one I highlighted in the red. So this is etanercept. This is one of the very few biologics that, came in the market again 14, 15 years ago. And, those are like blue, orange, gray, and yellow. Basically, this is, the outcome. PASI is basically PASI 50, mean reduction in psoriasis by 50%. You can see it here. PASI 75, reduction by 75. PASI 90, reduction by 90. PASI 100 reduction by 100%, basically complete resolution. And look at those medications, etanercept here. We would be happy if half of our patients would achieve 50% reduction in this psoriasis, PASI 50. But things have shifted as you go a lift, and look at the last 4 or 5, options or, agents that we have, now in the market in the last 2 or 3 years. Achieving PASI 50, which is a clearance of 50%, that's almost 100%. So all our patients, by 12 to 16 weeks, with 3 months of treatment, you would clear 50% of their skin. Not only this, PASI 9, PASI 75. By 12 to 16 weeks, 75% of the psoriasis is going to be gone. And PASI 90 to 100, anything between 40 to 60%, they're going to have even semi to 100% clearance within 3 months. Think about, those days in 10, 11 years ago, when we used to kind of, kill their liver with methotrexate for like 6, 7, 8, 9, 10 years. John Marshall and his friends, we were, kind of make a living for them. I'm just joking, but, basically, we would, use methotrexate for a long time that, the liver would be damaged. Now in 12 weeks, we can achieve what methotrexate or what other treatments that, we're not able to maybe achieve in 10, 15 years of treatment with almost no side effects. Now, with those new selective treatments, all what we see just like, kind of simple things, injection site reaction, some, kind of mild headaches practically. Yeah, there are some rare side effects, but mostly, a huge change. And again, look at these patients. Think about, how we treat these patients, kind of 10 years ago. As I told you, they were not improving. Their joints would be still hurting. They would be covered. And now this patient with one of the interleukin-23 inhibitors called tildrakizumab, after 2 injections, 4 weeks apart, they are almost 100% clear, almost. So this is one example. I want to share with you even, alopecia areata. As I said, those patients are amazing. They are awesome. They are beautiful inside out. They're beautiful outside as well. But again, they have a hugely impacted by this condition. If you have friends or, family or, a lot of them, they are just dealing with might be depression or, anxiety. And alopecia areata totalis has been studied extensively in terms of impact on the patients mentally. And yes, there is not much increased mortality, although, there are some, links with, kind of more suicidal thoughts and attempts. But, those patients, they have 8 to 7 more times depression and anxiety than general population. So, think about, if you have 100 patients or 100 people, and probably the depression is probably 10%, you would probably have 80% of alopecia areata totalis would having depression, and 70, 60% they would have generalized anxiety. If you meet those patients, they are, kind of, I'll probably say devastated by, this alopecia areata totalis, especially in female population. And it has a huge impact on their emotion, behavior, sexual life, social functioning is, they become socially dysfunction, they just cannot concentrate, productivity. I do remember one of those patients, he was having alopecia areata totalis and vitiligo, and he would be waiting outside. It's like, Dr. Abu-Hilal, I'm sorry, I'm waiting you outside, please help me. And I would feel like, I don't know what to do. I would just keep discussing with him, but we were not able to do nothing for him. And we were just giving him steroids, and nothing. And they would just keep, changing physicians, dermatologists without improvement. But things change, over the last, 10 years, a lot of research happened. And now, we can treat those patients thanks to the JAK inhibitors. Those patients, look at this study published in the New England Journal of Medicine. We can actually grow their hair fully, completely, almost in 30% of those patients, versus 3% placebo, within 24 weeks. So within 24 weeks, 36 weeks, you could have your hair completely back. And again, you look at those patients, I don't want to, overwhelm you with, kind of scores and everything, but it's just very self-explanatory. Look at those patients 10 years ago, 15 years ago, we would do everything possible from all the immunomodulatory agents. We would give them 1.5 milligram per kg prednisone, and trust me, they would not improve. And nowadays, within less than, probably half a year, they probably would be able, a good portion of those patients would be able to regrow their hair almost completely by 36 months. And you know what, you can't imagine about how many stories we heard about patients, coming and hugging us, and what, they just believe how this changed their life, how this is a game changer for them. Another one I want to share with you is vitiligo. Since vitiligo is one of those conditions that, again, another type of patients that got devastated by this condition, especially in people with darker skin, people with skin color, indigenous people, in much less, impact on people with fair skin. But it's used to be with, one of those conditions that we cannot do anything for the patient. I mean, probably I'm wrong. This is a patient that, was treated in 2012. And as you can see, she completely repigmented. Do you know 12 years ago or 10 years ago, how did this, happen? How did she had like this excellent improvement? It's actually, if you read here at the reference, this is makeup. The only thing that was making patients, making those spots would disappear is makeup 10 years ago. We were not be able to influence those patients. We were not able to change their lives. The only thing we would, tell the patient is camouflage. Just go and use a medical makeup, just a makeup, and cover it. Those people, again, similar to all those conditions, higher risk of depression, suicidal thoughts, anxiety, substance abuse. Even the quality of life, the studies, epidemiological studies, and quality of life studies show that their quality of life is equal to somebody who has class 3-4 congestive heart failure. So imagine somebody who's dying, I won't say dying, but dealing, with a life-threatening condition, cannot breathe. This is how impactful this condition in those patients. And again, this is not the case anymore. Another, breakthrough in dermatology, that those patients now, we have some excellent treatments, and there is actually more coming. So this is another topical JAK inhibitor. So JAK inhibitor, Janus kinase inhibitors. And as you can see, those patients, 30% of them, they would have almost at least 75 to sometimes 100% resolution of their vitiligo, a condition that was impossible to treat, by 24 weeks. By 4 months, you can achieve almost complete clearance. So those patients, they would have their pigmentation back in 4 weeks. And this is one of the patients, from Yale Dermatology. As you can see, almost complete repigmentation in 4 months. And this is again one of the major breakthroughs in dermatology, and there are more coming to in the next couple of years. Hemangiomas, again, we said this is medicine, but I want to share with you a couple of small things. So we discussed this, the mother's parents would be coming like, well, yeah, I'm not worried about cancer, but look at this, is my daughter is going to be dealing with this in her face for the next, you said 10, 12 years until maybe spontaneous regress. And I was like, no, you know what? We have two options. The first option, I can send you to a plastic surgeon that, can cut your daughter's face from, kind of top to the chin, and you end up with a scar, or I can give some prednisone that, would give her Cushing syndrome. But you know what? That's not the case anymore. Again, thanks to the, advanced research and advanced therapeutics. Now dermatologists are, the second, would you imagine that dermatologists, other than cardiologists, would be using beta blocker propranolol systemically, oral propranolol for medical conditions. So now hemangioma, there is an FDA treatment, which is oral propranolol. If you take it in 2 milligrams per kg, that can result in a complete resolution and evolution of the hemangioma within a few months. I don't want to talk about pathophysiology. It's more about apoptosis, induction of apoptosis. But, those patients, look at them, within 6-7 months, they would have no birthmark in their face. The hemangioma would be completely involuted. The same thing, with this patient that, the mother was, completely not happy. You can just hopefully convince them about, how safe the treatment is, and, how it can, give an excellent outcome. And a lot of, parents would buy in treating their lovely kids. Now, we are in medicine, so some of you would ask, Mo, that's great. That's great for you. That's great for dermatology. But how is it going to affect us? What about, dermatology for medicine? What about dermatology for internal medicine? What about dermatology for some other subspecialties? And again, there's a lot of things. I'm going to share some sample of this. As we discussed, Pemphigus vulgaris, a very severe debilitating condition, tons of ulceration, skin, oral mucosa, nasal mucosa, genitals, scalp, even sometimes can go deeper. those patients, you know what, they would be admitted to the hospital many times, 5-6 times a year. In fact, you know, again, you know what, those showed that, you know what, an average cost of a patient of Pemphigus patient admission in the States, at least, it's almost, you know, close to 100 grand. It's almost like 75,000. And what's interesting that, you know, the studies showed that, you know what, it's a rare condition. It's not like a heart failure or, you know, asthma. But if you have 10 patients, the same number of those conditions, like, for example, asthma, CHF, Pemphigus vulgaris, you know what? Pemphigus vulgaris, a dermatology condition, it would rank among the top 10, 15 conditions in terms of rate of admission rates. This is, you know what, patients, they would be getting, you know, to the hospital, recurrent skin infections, you know what, they cannot eat, they cannot drink, they are, you know what, dehydrated, they could have acute renal failure, they would have, you know, some of them are old, but they would have, you know, confusion. So they just would be all the time, you know, going to the ER and to the hospital. And actually that's, we see even in the last few years, you know what, I get a lot of calls about those Pemphigus patients that, you know what, there is no good treatment for them. And, you know, they just keep getting to the hospital. And this condition, we did not have till now, like, you know, probably until, you know, a couple of years ago, we did not have some great targeted therapy for Pemphigus. So all we can do is doing azathioprine, mycophenolate, and you know what, it has a variable response in different patients. Some of them, they would improve, some people would not. They keep, you know, getting again to you guys in the hospital, in the ward, and the emergency. And even those treatment did not, the study showed, reduce the admission rates to the, or, you know what, visits to the hospital. Until again, you know what, in the last couple of years, you know, we had another study published in the New England Journal of Medicine that, you know, showed that rituximab, that given in 2 doses, you can just give the patient rituximab 2 doses apart, 1 gram, 1,000 milligram, 2 weeks apart, can result in remission and almost resolution for years. Not resolution, but basically remission that can last for years. Could range from 6 to 12 months, or sometimes even for, like, you know, start from 6 to 12 months up to sometimes several years. So now rituximab is considered the first-line treatment for patients with Pemphigus. And literally, you know, we had a patient a month ago, 2 months ago, you know, he was, you know, Dr. Khalid Azam team, you know, consulted us. And you know what, this patient tried everything possible in the past and nothing helped him. And you know what, we just, you know, and he was getting to the hospital, to the Hamilton General, almost every 1 or 2 months with just infections and dehydration and, you know, and all these, and even sepsis. And you know what, with a couple of doses of rituximab, you know what, he's now hopefully, I don't know, but hopefully he will not be jumping into your, you know, ward frequently. So, I mean, look at this. This is a patient with rituximab before and after. And again, this is not just, you know, that it's improving, it's remission. It's going to be, you know, for a longer period of time. Even patients with atopic dermatitis, we get a lot of, you know, kind of, you know, referrals from the emergency. You know what, patients with eczema, they keep, you know, getting, you know, to the emergency. You know what, they cannot sleep, they scratch, they get infection, they get skin infection, they get MRSA, they get herpes zoster, they get herpes, they get even, you know what, osteoporosis, they get getting a lot of prednisone, they get osteoporosis, they get cataract, they keep going to the emergency and, you know, get admitted for, you know, IV antibiotics. A huge burden also, again, mentally, and you know what, mental health. You know what, patients with moderate severe psoriasis, eczema, they would deal with a lot of anxiety and depression and massive reduced quality of life. As you can see in this slide, this is, you know, kind of what, almost 60-70% of those patients, they would have anxiety and depression and reduced quality of life. So how we used to treat them? Nothing, topical steroids. But, you know, this is not the case anymore. In the last, you know, kind of 5 years, we have at least 4 approved treatment for, you know what, atopic dermatitis, moderate severe. And you know, in the name of abrocitinib, upadacitinib, dupilumab, etrolokinumab, those are biologics and some advanced oral therapies. And there's even a 5th one in Europe. And again, similar to psoriasis, you know what, not only just we have some really good treatments, it's basically, you know what, even the outcome, you know what, if, you know, initially we used to think, oh, you know what, we want them to be better. You want them to scratch less. Now, not this, this is not the goal anymore. Now we would love them to have almost 75% of their eczema is resolving and, you know, improving. And look at this, you know what, we can achieve in around, you know, 60 to 70% of them, we can get them to have at least 75% of them, you know, having their eczema improving. And even now we have even different goals. Now we're aiming for EASI 90, which is, you know, kind of reduction of their eczema by 90%. not as promising, or as we are not as happy in psoriasis, in eczema as much in psoriasis, but at least I'm sure that in the horizon we'll be able to kind of reach those goals. There are some medications that can induce this, but probably we need better agents in the next few years. And look at those patients, those would be using topical steroids for kind of months and years. Now, with those simple, somehow safe treatments, you can get them to have their skin clear, and they go back to their life. They could be productive again. They can be socially functioning. They can be just socially not isolated. They can go back to their social life without any issues. This example we talked about at the beginning about our engineer that quit her engineering job because she was not able to focus. It was having a big burden on her. And are we done? No. It's not just about eczema in adults. Imagine that we talked about propranolol, what we dermatologists, we use it other than cardiologists. Nowadays there is a biologic treatment approved for infants with eczema. So imagine that 6-7 months old, dealing with severe eczema. Our folks in pediatrics, they would keep seeing them every month in the emergency for those infections, covered with the eczema. Dermatology is one of the first, if not the first, approved treatments in infants for inflammatory condition, other than more those genetic ones. So we're not done with this. And we talked about subspecialties, dermatomyositis. We talked about how sometimes those conditions could be severe. Look at those patients; they would have rashes all over their body, and despite being on methotrexate, Imuran, and all these big guns, even cyclophosphamide, their cutaneous manifestations would still be present, but again, not anymore, thanks to the JAK inhibitors. And those JAK inhibitors are going to change how we practice rheumatology and dermatology. And now those cutaneous manifestations that's probably I'll probably say a few years ago we used to think it's impossible to kind of control it 100%. Nowadays, we can clear them. Look at this patient. This patient was having what we call, the V sign, the Scholl sign, and some, patches in the body. And, with the help of tofacitinib, which is one of those JAK kinase inhibitor, we can clear the skin completely. And also, works very well in the muscle. And actually, I shared a case, one case or two cases in the last couple of months. Patients with dermatomyositis and with the rheumatologist in St. Joe's, they were covered with some skin manifestations, and they were taking tacrolimus, IVIG, prednisone, and even in the past cyclosporin, and even sometimes they would add some kind of pulse doses of cyclophosphamide, and that's helping a bit of the muscle, but they would come, their skin is still active and flaring up. And we just decided to kind of switch, discontinue some of the other medications and add one of those, what we call them, JAK inhibitors. And, their skin would be completely clear within, kind of 3-4 months, and generally being, effective and safe treatments. This is, again, the similar patient. As you can see, you see the Scholl sign at the top of his back has resolved, with the JAK inhibitors. Now, are we again satisfied? Is this kind of the limit for us? Absolutely no. There's a lot of unmet needs for primary dermatologic conditions and some dermatology issues and things that you guys see again in the hospital. For example, or even infectious dermatology. So, for example, this patient with leprosy, we still have. We treat them, but we would love to have a better treatment. One of the, kind of biggest issues in the science of dermatology and again, medicine critical care is patients with Stevens-Johnson and toxic epidermal necrolysis. Till now, we still having gaps in the pathophysiology, understanding the pathophysiology and the treatments. Sarcoidosis, this is a patient sarcoidosis, even cutaneous sarcoidosis. There are some emerging treatments that is going to change, the game, and we'll finally be able to, treat their cutaneous manifestation sarcoidosis effectively and efficiently. And even, malignant dermatology, Kaposi sarcoma, scleromyxedema, and other conditions like even pyoderma gangrenosum, despite, we have some agents now to help, patients with pyoderma gangrenosum, the outcomes still are not as we wish for, and we still have gaps in managing those patients. And with this, I come to conclusion. And again, so dermatology is not just about having skin rashes or skin condition. It's much more deep. It has a huge impact on patients' quality of life and, and their psychosocial, impact in them is huge. While, a lot of those dermatology conditions that, we used to think, 10, 8, 12 years ago, it's impossible to treat. There is nothing that we can help them. A lot of those conditions now can be managed efficiently, effectively in the last decade. And the last thing I want to say that, despite, the dominance of the aesthetic and cosmetic aspects in the practice of dermatology in Canada, and not only in Canada, even around the world, in North America and in the world, medical dermatology is still here, is still present, is still strong, and will continue to have a massive positive impact on the patient's quality of life. And thank you.
Thank you, Dr. Abu-Hilal. We've got about just under 20 minutes for some questions. We've got some questions that have already come up in the chat,
Sure.
so I'm going to push these out. So Dr. Levine has a question. He said, are you concerned about increase in lymphoma and cancer when these drugs will now be used for 30 years?
That's a good question. The answer, definitely, we don't know, right? Like, everything now in life is evidence-based. Now we need to kind of look into what we call open label extension studies. We need to look into real world data. And what we've have so far with a lot of those agents is more like in the range of 5 to 7 real world, data. We have 5 to 7, years of extension studies. And so far, there was no statistically significant increase of risk of, malignancies or lymphomas or leukemias. But again, that's about 5 to 7 years. Now, personally, I think I am not sure. I cannot say yes or no. I probably tend to say no. It will not be a huge signal, a big signal. The reason is because, again, if you think about the pathophysiology of things, for example, psoriasis, if you are just targeting a one molecule, which is the underlying culprit for this disease, while you're almost kind of leaving almost most of your immune system intact, I don't see this having a long-term effect. As for example, if we're in mycophenolate, or maybe as a azathioprine, where probably you're just suppressing the whole immune system down and increasing risk of infection lymphoma. So I don't know probably the answer. As I said, that needs more long-term studies. But for now, what we know, in up to 5-7 years of a lot of those agents, we're not seeing a huge risk or increased risk of lymphoma.
Excellent. I'm just going to link that to a question from Dr. Gerstein, where it's asking specifically, what are the long-term harms of JAK inhibitors and other biologics?
Yeah, so again, this is almost the same question. This is what we just mentioned in a second. The only way to kind of look at the long-term data, what we know now for JAK inhibitors in dermatology, in rheumatology, some of the old ones, for example, tofacitinib, which is a very broad JAK inhibitor, we found that there is risk of lymphoma in those patients. But as we advance, as we get more targeted, is going to become more selective to those agents. We don't know. Maybe there's going to be some increased risk. But so far in a year, for those ones used in dermatology, so for example, tofacitinib, which is a JAK inhibitor, a very broad one, used in rheumatology, there has been some link to lymphomas. But those selective ones, so far, what we know that, over the last, year or two, the 1-year follow-up studies did not show any long-term outcomes, severe outcomes.
So Dr. Jones is asking, has there been any changes in the diagnostic approach to dermatological disease over the last decade?
To be honest, diagnostic approach means, like, if we talk about, I don't think, remember that, dermatology is a lot of time is it's still, you know what, a physician-patient interaction with the help of, you know, a bit of, you know what, ancillary, like for example, blood work, but not much change. You know what, we still depend, you know, we are the old British way of, you know, the medicine way of, you know, interaction, you know what, signs and symptoms and history, not much. Now we have some, you know, better diagnostic methods in terms of certain conditions. For example, bullous pemphigoid, Pemphigus vulgaris, there are some improved testing for those patients, but overall, as he said, there has not been much changes in the diagnosis approach.
Thank you. So as you had mentioned, it's part of your talk, you wanted the link to internal medicine and ED. I'm going to ask Dr. Ahmed's question, where she mentions that sometimes there's challenges of inpatient dermatology consultation, but the question really is, when is it important to have an inpatient dermatology referral, and which diagnoses should be prioritized to be seen urgently as an inpatient?
Well, thanks, Amna. That's a great question. That's a very important practical question. So again, I don't want to go to switch this to kind of why dermatology is not always in the hospital. But again, I just want to remind everybody that there's only a couple of dermatologists, you know, kind of covering 3-4 major hospitals. So, you know, I would say it's impossible. It's extremely hard to have just 2 dedicated dermatologists covering 3-4 major hospitals, maybe like 50, 60, 70 services between medicine, surgery, you know, and pediatric. But that's a very good question, because one of the things that, you know, sometimes we used to, you know what, frustrate us, that, you know, sometimes we would go to see, for example, oh, a pigmented lesion. Now, yes, pigmented lesions could on paper be a bit of, you know, melanoma, but that is not something that, you know what, you need urgently, acutely at that moment. You know, you can be immediately, you know, kind of followed up in the clinic. I think I always say that, you know what, there are at least 3-4 conditions that definitely, you know, need to be focused on. The first and the most important one is, again, those what we call severe or, you know, Stevens-Johnson, suspicion for Stevens-Johnson syndrome / toxic epidermal necrolysis. So those patients, anybody whose skin is exfoliating, you know, they're having peeling, they're having erosions, this is a definitely important one, because this one is associated with probably increased mortality if there is delay in diagnosis and there is delay in the management. And that generally applies to most of those severe drug reactions. If you have a patient that you suspect they're dealing with what we call DRESS syndrome, severe hypersensitivity syndrome, people, you know, dealing with those severe immunobolus conditions, like, you know, kind of, as I said, a couple of months ago, Dr. Azam called us about his patient. He was covered with erosions with Pemphigus. So, you know, SGS, TAN, severe drug reactions, immunobolus conditions are probably top 3 for things that usually we feel, even from interest perspective, you feel like, oh, this is very important, I need to go and help, and, you know, see how can again, you know, help you and help the patient.
Thank you. We have some questions from Dr. Puntiki, Dr. Kurnu, and an anonymous attendee. I'm going to link these questions because it looks like it's a similar theme. The first question would be, do we know what triggers some of these autoimmune processes, and how do we turn them off? And then there's also questions about, do the treatments need to be continued lifelong, or do these treatments reprogram the immune system, allowing these medications to be stopped?
Again, also a couple of excellent questions. I'll go backward. In terms of, do we need to do lifelong? You know, I won't say there's a debate, but you're going to see some different schools here. You know, one school, they would just say, you know what, we similar like you guys, you know what, if we have, you know, let's say, you know, a nephrologist, or, you know what, you will not give him the blood pressure medication for just a month, you know, for a year, then, you know, stop it and treat it again. So some school, they say, you know what, no, it is need to be given, you know, kind of indefinitely, as long as it's effective and safe. There are some schools that, you know, they still believe in what we call the pulse, the intermittent therapy, because some of those conditions, as we discussed, that sometimes when you treat them for a certain time, for example 6 months, taking an example psoriasis, take about an example sometimes bullous pemphigoid, sometimes you treat them, you go into a bit of remission for 1 or 2 years, so you don't need to continue. Some of them, not all of them. The issue that we don't know who is who. We don't have those markers, those predicting factors that tell us who's going to be needing the medication, consistently, and who's going to go into remission. But you're going to see some schools that, do it indefinitely. Some people, sometimes, either the physician themselves or the patient, oh, I'm feeling well. We stop the medication, the psoriasis, the bullous pemphigoid, maybe even, sometimes the alopecia areata. We have some patients that, you treat them, they grow their hair back, you stop it, they do well. It doesn't come back again for many, many years. While some people, it might recur. So 2 schools till now, we would love to know which one would need continuous, which one we can do it intermittent, but it's both are valid, as long as we discuss it with the patient. Now, in terms of what triggers this, most of the dermatology conditions are autoimmune conditions. So we don't know, what exactly. It's not like a simple drug. It is not just like a food. It's an autoimmune thing. Now, as much as we don't know what's the trigger, our understanding of those conditions, has, as we discussed, advanced drastically. So again, those conditions, we used to think it's just a bit of loss of hair. Then we think, there's actually this molecule and molecule A and B in this condition. Then found even certain part, there is part of this molecule that's involved. So we're narrowing and becoming much more selective, and we have a better understanding. So it's an autoimmune that we don't know what exactly the trigger, but we have a very good understanding in a big part of those dermatological diseases. And we still, there are some other ones we don't know what's the pathophysiology.
Thank you. Dr. Cox has a question. Dr. Cox mentions regarding sarcoidosis, and you'd mentioned that there's new therapies for patients with cutaneous sarcoid. Can you please tell us more about these therapies?
Yeah, I think I don't know too much about those going in phase 1 and phase 2, but I think with Jerry we shared again a couple of patients where there is a growing evidence of, for example, those medications that we call JAK inhibitors. So JAK inhibitors, what we call Janus kinase inhibitors, are medications that work again in the a smaller level than the cytokines level. They mediate those Janus kinases, the effect of those interleukins and cytokines. Now, our colleagues in dermatology, even pulmonary, they use sometimes those JAK inhibitors. But what's even more interesting, that there are topical Janus kinase inhibitors. So those Janus kinase inhibitors, they might come with some random side effects in terms of liver or kidneys, could be transient. But even the advances now that they are going to come in the next couple of years in terms of topical formulas, so that I can manage, for example, a patient with one of Jerry's patients with some sarcoidosis in the skin, can use them with topical Janus kinase inhibitor rather than systemic agents. And again, to my knowledge, in some of those phase 2 trials, they've been showing some really excellent outcomes for patients with cutaneous sarcoidosis.
Thank you. I wanted to ask you a question. I saw in your graph you showed that some of the newer therapies for dermatological diseases, specifically psoriasis, are now showing high levels of effectivity, almost to 100%. 70% of patients get 100% effectiveness with the newer treatments. Do patients have access to these newer treatments, or do they need extended approval? Do they have to fail earlier treatments? Or do they will they all have access to the treatments that have high response rates?
Again, another excellent question. It's a very complex answer, because remember that there is a private payers, there is governmental, let's call it, plans. So the access varies between patients. Some of our patients are lucky enough to have access to private insurance, where a lot of times we don't need to go through any other treatments. In dermatology, we can just prove that they're dealing with some severe psoriasis that impacting their life. And, some insurances, they would, accept, going to those medications as first-line treatments. While, if we are mostly talking about, formulary OHIP plus, and for example, senior benefits, or, senior benefits, yes, they need to go through, the hierarchy, or, going through some of the older conventional medications like, methotrexate and other things. Now, again, this is a complex because a lot of times, our population, they deal with some other comorbidities that, does not allow us to use methotrexate, drinking alcohol, liver, fatty liver, sometimes a bit of, renal dysfunction, sometimes taking medication that interact with the cyclosporin or methotrexate. So, sometimes we still are able to get them to those medication, but yeah, it varies between patients.
Thank you. So we just have a few minutes before 9. There's 2 more questions. I'm going to bundle them. It's from Dr. Puntaki and Dr. Kurnu. Number 1, do these treatments, which are used for skin conditions such as psoriasis and dermatomyositis, also treat the non-dermatological portions? And from Dr. Kurnu, is there any important side effects that we should be looking out for these treatments that are treated from dermatologists?
Yeah, in terms of, those systemic and biologic agents, for example, for psoriasis and possibly dermatomyositis and other conditions, yes, a lot of them, not all of them, a lot of them. So I don't know if we have rheumatologists, among us, and even cardiologists. So a lot of those treatments, for example, in psoriasis, are now approved for not only psoriasis, cutaneous psoriasis, for psoriatic arthritis, and even some studies show that it's actually, help in reducing the inflammation in the coronary arteries and kind of generally vascular inflammation. So it does, target not only the skin and also, most of the joints and sometimes inflammation and elsewhere in the body. Some of them not, some of them they just approved for skin, but I'll probably say most of the good ones, they are actually effective for both. And that's actually one of the, again, good things that, you can kill 2 birds with 1 stone. Sometimes you can kill 3 birds with 1 stone. And the same thing applies actually, for example, you mentioned dermatomyositis. There are, for example, those phase 3 trials that going on those JAK inhibitors. And for example, dermatomyositis, then only now we know that they just like there is the skin manifestations, there's the muscle, and there is even sometimes interstitial lung disease and some other things. And again, there is a growing evidence that those treatments are actually not only just help the skin, but also help this the muscle part, and also helping those concurrent interstitial lung diseases and some other things. So yes, they usually most of the time effective not only in just on 1 organ and usually multiple systems and multiple organs. What are the side effects you need to watch? Again, that varies by indication, the class of medication. With the newer agents for some of the biologics for eczema, psoriasis, rituximab, other than the time of the infusion, the practical side effects are very, very low. We don't see much with interleukin 23, interleukin 17 inhibitors. Now, some of those, especially when we discuss the JAK inhibitors, we dermatologists, the primary physician involved in those, we do some, kind of monitoring with mostly for the kidneys and the blood counts. That being said, we know that, most of them, they do well. And very few patients, they would have transient cytopenias and transient elevation in sometimes liver enzymes.
Thank you very much. Thank you for today's rounds. It's 9 o'clock. I think we had a wonderful chance for lots of discussion. Everybody have a wonderful day, and thank you very much, Dr. Abu-Hilal.
Thank you, Mohannad. Thank you, everybody, and looking forward to seeing you guys again. Bye.